Good morning, afternoon, everyone. If you haven't done so already, I'm going to invite you to mute yourself. Feel free to ask questions throughout the presentations, either in the chat or out loud. I'm sharing a link if you would like continuing education, medical or nursing credits. We have those available for attending these sessions. So if you would have to complete the roll call, and then you'll have to complete the evaluation, which the roll call actually leads you to. I'll share that a couple times during the session. Towards the end of the hour, if you just want to give us evaluation and you don't want CEU credits, I will share also an evaluation link. And that is all I have. Oh, our next echo for these calls is going to be December 4th.
Thank you, Emily. We'll go ahead and get started with Amani Ransby to present on national area updates.
Good morning or afternoon and welcome everyone. Today I'll just be giving our usual update on the national area epidemiology as it pertains to COVID-19. For those that are joining us for the first time, this update just consists of looking at some of the data points that are currently included in our USET area aggregate report. And please note that these surveillance reports are sent out to our member tribal nations and USET staff every Tuesday. So you should have had those available for you to view as of 11/10 this past Tuesday. So the following slide lists the number of new positive test results, the cumulative total of positive test results, as well as a 7-day positivity rate or percent positivity for the week of 11/2 to 11/9. Just to note, these numbers are produced from the sites that are currently reporting testing data to IHS or the Indian Health Service. I believe we have 26 sites currently reporting to us. And so for this week, the number of positive COVID-19 tests at reporting facilities in the IHS Nashville area in the last week was 96, while the cumulative total of positive COVID-19 tests was 2,072, and the 7-day positivity rate was 6.7%. I will note that the number of new positives did decrease slightly from what was last reported on the 11/2 report. And you will be able to see this on the graph that I have on the next slide. However, the positivity rate has remained around 7% and hasn't really decreased or increased here. So I mentioned this on the last echo, but our rationale for including the positivity rate is that it can be a meaningful data point to tribal nations that may be doing a lot of COVID-19 testing on asymptomatic people. If you are seeing a high positivity rate, that would likely indicate widespread COVID-19 infections within your community, and generally this rate will decrease as the amount of negative test results increases. Alternatively, the more positive test results you have, the higher that percent will be. So this line graph that's on the slide here shows the number of new positive COVID-19 test results from week to week over a 12-week period. As I mentioned on the last slide, the total number of new positives for this week was 96, an increase from last week's number, which was 79. And from this graph, it does appear that we are continuing with an upward trend as time does pass. I'm specifically referring to the numbers for the more recent weeks, although you can compare the amount of new cases between now and as far back as mid-August at this point, since we are giving you that 12-week retrospective look at the data. As the pandemic continues to progress into the fall and winter season here in the US, it does look like we are seeing notable increases in the amount of cases in our region, but we will continue to track this. In addition, we will be issuing a holidays and COVID-19 guidance for consideration document that I believe is in the works and just aims to provide recommendations for attending or not attending family gatherings and how to reduce the spread of COVID-19 this holiday season. So be on the lookout for that. And so the following graph showcases the rate of new COVID-19 cases per 10,000 by USET counties, USET states, and the United States. Again, we've included a 12-week period or time frame for this graph so that you can follow the trajectory of the outbreak over time. Please note that these rates are not limited specifically to tribal citizens and were obtained from the CDC and state health departments that are currently reporting testing data. And as mentioned on the previous echoes, we do continue to support using the surrounding areas as an indicator of what's currently going on in our USET region. But from just taking a look at this graph, you can definitely see that across the board, the rates are increasing over time, especially in the more recent weeks. So overall, the rates do seem to be on the rise again here. And specifically for this week, the PERCTA purchase and referred care delivery area or USET county rate was reported as 20.98, while the USET state rate was recorded as 15.81 and the United States rate as 22.27. So the US rate was highest, followed by the PERCTA or USET county rate, and then the USET state rate for this week specifically. You can also see that the USET county rate does appear to have had a rapid increase and even surpassed the USET state rate this week, indicating a noticeable increase in the number of COVID-19 infections on the county level specifically. Okay. And so just as a reminder to everyone, we do have the COVID-19 surveillance tool available for you to use for tracking COVID-19 cases. Please note that this tool can be modified to meet the needs of your tribal nation if need be. But if you do have questions or concerns related to getting set up with a REDCap account, or if you just need general assistance, please do not hesitate to reach out to us at usetinc.org. Thank you.
Thanks, Imani. Do we have any questions for Imani at this time? If not, we'll move on to Dr. Mera for his presentation.
Can you see my presentation, Brian? Okay. All right. So I'm just going to give, so Brian asked me to give the overview of the COVID. I hope this is the one that you were asking, Brian, right? The overview of COVID. Yeah, I get, so this, I lost track of time with COVID, and what I did last week, it seems like I did it yesterday and vice versa. So that's why I need some checks in place. So I'm going to cover just an overview of what we know about COVID and some, things that we don't know yet. As a summary, we are inundated every day by a lot of trials and information. Some seem to be important, but the majority seems to be noise. And so I think kind of taking one step back and summarize what we know now, I think it's important. So this first slide really gives all you need to know about prevention, which is, you can see the two gentlemen on the top. They're maintaining distance around 6 feet, I would say. They're both wearing masks, and the sanitizer on the bottom just reflects that you should be washing your hands frequently. On the right, you see a figure of the virus, which looks very beautiful. Only the figure is beautiful about this virus. And it has these little red spikes, which are the surface proteins in which many of our antigen tests are based on, and many of the vaccines use this structure to elicit antibody production when you receive that. And it's called coronavirus because corona means crown. So if one of you thought it was because of the beer, no, the answer is not because of Corona the beer. It's because if it looks like, it gives a crown shape, especially when you look at it at an electron microscopy, it looks like a little crown. So coronaviruses are not new. Human coronaviruses, we always have every year 4 types that circulate. These are the ones in the yellow boxes. And they are responsible for a good proportion of our colds, 15 to 30%. They're seasonal, Sometimes they can cause bad disease, meaning pneumonia. And, in Cherokee Nation, we've been tracking them in the last 3 years because we do film arrays for everybody who gets admitted with a pneumonia. And we see the seasonality of these coronaviruses every year. But the ones that are under our attention right now are the more severe ones that have the potential for pandemics and also for causing more severe disease. So we've had MERS and we had SARS-CoV-1 in the past. They were auto limited, but now we're dealing with SARS-CoV-2 that you are well aware of. And just to refresh our memory, SARS-CoV-2 is the name of the virus, which stands for Severe Acute Respiratory Syndrome Coronavirus. And the number 2 is because we had a number 1 in 2003, and this is the second one. And the disease is a COVID-19, which stands for coronavirus disease, discovered in 2019. So by now we all know where this started. It was in the city of Wuhan, the province of Hubei in China. This was reported in December of 2019, and 2 weeks later, the virus was identified. And I'm never amazed on how fast this was done. Just to put things into context, AIDS was defined in 1981, and the virus was isolated in 1985. It took 4 to 5 years to isolate that first RNA virus. It took 2 weeks to isolate COVID-19. So how did it get spread? Probably it jumped from a bat, either directly to humans or from a bat to a reservoir host. In this case, it was the pangolin, which is a scaled little organism, or not organism, little mammal in China. And then once a human got infected, so what has changed from today compared to the 1917 influenza pandemic was that now we get on a plane and we get to the other part of the world in a matter of hours. And so probably that was the mode of dissemination of the virus, that in a few months, the whole world was infected. So this graph is from a week ago. And a week ago, we had 48 million confirmed cases of COVID-19 in the world. And 1.2 million deaths, of which the United States is the number 1 in number of deaths compared to other countries. We have over 240,000 deaths, I believe, so far, and it's climbing. So this is just to compare the United States with Europe, Asia, and Africa on the cumulative confirmed COVID-19 cases per million population. So this is not absolute. This is relative to your population. And the United States bears the worst burden compared to any other continent in the world. And the reason is not surprising. We don't have a national plan. We have state plans. And it's like we have 50 countries in one big nation instead of having one national plan guiding on the preventive measures that need to take place. That's why many other countries have fared a little bit better than we have. So what do we know about transmission? The main mode of transmission is droplets that are greater than 5 microns and that are spread around 6 feet around the contagious person. And why 6 feet? Because these droplets are big and they tend to precipitate and fall to the ground within that distance. But we do know that in some cases, smaller drop particles or droplets are generated that are less than 5 microns, and we call them aerosols. They can be suspended in the air, and they can sometimes travel much farther than 6 feet, up to 20 or 30 feet. Now, this is not the main mode of transmission, or we would be all infected by now, but it can happen in certain situations. Like the perfect storm would be being in an indoor area with poor ventilation and someone singing. That's like the perfect storm to get everybody infected. Less commonly through fomites. You can sneeze on a surface, someone can touch the surface. If they don't wash their hands and take their hands to their eyes or mouth, they could potentially be infected. We don't believe this is a predominant way of transmission, but it definitely can happen. And finally, we find the virus in stool, blood, and semen and other secretions, but we don't know what role they play in transmission, if any. So here's just to show you that when someone is sneezing or coughing, the particles they can generate go from 0.1 microns to 1,000 microns. So if they're greater than 5, they will precipitate within 6 feet. But if they are smaller than 5 microns, they can travel up to 20 feet or further. The other thing we've learned is that probably the drivers of infections are silent shedders, meaning asymptomatic people who are talking, singing, and they are transmitting the virus. In some series, up to 79% of the infections came from asymptomatic transmitters. So 6 feet of social distancing will not protect you if the particles that are being generated are very small and if you're indoors with poor air circulation. So we know that the incubation period still holds. It's 5.1 days with a range of 2 to 14. That's why we use a 14-day quarantine parameter. Close contact has been recently redefined by CDC. It's still within 6 feet, but the 15 minutes are cumulative, meaning if you're within 6 feet without a mask for 5 minutes and you go away and you come back for another 5 and you go back and come back for another 10, you've been 20 minutes exposed. And that's why households of a person who's infectious tend to get infected, up to 40 or 50% of them, because they're there for a long time. Isolation is still the same, 10 days for non-hospitalized patients, 20 days for individuals who have been hospitalized or who are immune compromised. There's 3 types of masks. The important thing is that the keys to interventions is universal use of masks or cloth face coverings to maintain physical distance. And we know that the magic number is 6 feet, but I just want to remind you that 9 feet is better than 6 feet, and 6 feet is better than 3 feet, and 3 feet is better than 1 feet, or 1 foot. So the farther away you are, the better. So if you're in a classroom and you can put people 9 feet away, that's the way to go. Because the distance is probably the most important factor in the transmission. Avoid crowds, avoid indoors, and frequent hand washing. So the 3 masks that we have here, the N95 is only exclusively used in healthcare settings, especially where aerosols are being produced. And that's mainly when patients are getting nebulized or intubated or on a vent. That's where you really have to use the N95s. The surgical masks are also pretty restricted to healthcare settings, but I want to mention one thing that I've learned over these last 6 months. The initial recommendation for the people that are not part of the healthcare system to not use surgical masks was mainly done because we didn't have enough surgical masks. So if a patient asks me, because now you can walk into Walmart or Costco or whatever supermarket you go and you'll find a box of surgical masks available. So if someone asks me, is a surgical mask better than a cloth mask? And the answer is yes, it is a little bit better. So if you have the possibility of using a surgical mask, I think that's fine. And I don't think we are in shortages of surgical masks. We are in shortages of N95s. But a cloth mask is better than anything, than nothing. And a cloth mask not only protects the people that surround you, but it also does give you some protection. At the beginning of the pandemic, we thought it doesn't protect you, it protects the rest. But now we know that especially if they have 2 or 3 layers of cloth, preferably cotton over synthetic fibers, just because it's easier to breathe with cotton, it is helpful to have them. And like I said, we need a universal mask mandate, like it or not. I don't know what your personal beliefs are, but this is science. Masks work, and we have a pandemic that's killing thousands of people every day. And it's the best we can do for ourselves and for our neighbors is to wear a mask. So what I tell people is just get over it and put a mask on. Okay, here's the virus. It's the inner part is what you see there in red like a little worm. That's the RNA. That's what our PCR tests target. They amplify this RNA and we detect it. Our antigen tests detect the surface protein that you see here, the spike protein. And this is the spike protein enlarged, and you see a little red thing in the middle of it, which is called the receptor binding domain. That is the very specific epitope in which many of our antigen tests target and our vaccines also target. You know, of all the graphs I've shown you in the last few months about how to interpret, you know, serology or antigens, I think this is the graph that I like the best. It's the simplest one. And basically what it tells you is that within the first 7 days of onset of symptoms, the best test is a PCR to detect a symptomatic individual, which is an RNA test, or a test that detects RNA. And antigens tests are good, not as good as PCRs, but they're fairly good tests too. So if you don't have an RNA test or a PCR test, antigen test is the way to go for symptomatic individuals if you don't have PCR. So it's a good backup test. After the first week is over, you can see that the PCR test and the antigens test start losing their capacity to detect people who got infected, and the antibodies start going up. And the peak of antibody detection is around day 14 to 21. So 2 to 3 weeks after symptoms start, that's your best shot. Now, we still use for symptomatic individuals PCRs or antigens. The role that I give to antibodies is, you know, we see individuals who said, I've been sick for 3 weeks. I've been tested with antigen or PCR that have all been negative. I don't know what I have. Well, that's a moment where an antibody may help you sort that out, because 90% of the individuals who are symptomatic will have an IgG antibody by week 3. So that's how I use the test on the clinical field. Of course, the epidemiologist, it's a great tool for surveillance, for serosurveillance of your communities. And they use this information very thoroughly and thoughtfully to give epidemiologic information, which is critical to be evaluating the pandemic. So regarding when you have a patient who's symptomatic, the nasopharyngeal swab is still the standard. It performs better than nasal, probably more or less the same than saliva, but we still don't have a saliva test that's been practical, let me put it that way. I mean, there's a lot of research on it, but we still don't have access to them. And it performs better than testing in other fluids. But also the timing is important. Within the first week, nasopharyngeal PCR is the best test. After week 1, maybe sputum, if patient's having pneumonia and coughing up some sputum, probably the sputum looks a little bit better. Antigen test is 80% sensitive compared to PCR. Now remember, PCR may miss 20% of the people, so it's not a perfect test either. And then serology, I already mentioned. From a clinical point of view, week 3 or 4 after infection is probably the best bang for your buck to serology be positive when you're using it. Symptoms, every week we have a new symptom added on the list, but I'm seeing patients 3 times a week, and the symptoms that I see more commonly are headache. It's very common and very prominent and difficult to treat. Cough is very frequent. Loss of smell and taste. I've seen it in about 10 or 15% of the patients. Now, when they have that, it's very suggestive that they have COVID, but the absence of it does not rule it out. Shortness of breath is extremely common, even on people who have normal CTs and they have normal oxygen saturations. So there must be something about this virus in the interstitium of your lung triggering your dyspnea receptors and making you feel like you're short of breath. But that's very common and it lingers for a long time. Nausea and vomiting, we see it 20 or 30% of the times. Fatigue is very common and is one of the symptoms that tend to linger in time. So there's 3 symptoms that persist for weeks in some patients. Fatigue is one, cough is the other one, and shortness of breath is the other one. So I have patients that are 4 to 5 weeks out of their infection and they still have these symptoms. Doesn't mean anything bad as far as we know, but it's just important to tell patients that it's quote unquote normal to have that or common to have that, and to reassure them that it'll go away. They just need to weather it out and be patient, more patient than what they have already been. So once you get COVID-19, who is at risk for not doing well? So the main driver is age. The older you are, especially above 6, starts at above 60, but The older you are, the worse your outcome. And I get very nervous when I see a 70-year-old with COVID because they're at a very high risk of complications. Now, anyone with a comorbidity is at high risk also. The comorbidity that seems to be standing out is obesity. So if you have a body mass index greater than 35, you have a high risk of not doing well. So when I say high risk, what percentage am I talking about? So when a patient comes to me for the first time and they have COVID and I just diagnosed them and they ask me, they're scared and worried, and they ask me what are my chances of doing well or bad. So overall, regardless of their age and their comorbidities, I tell them that 81% will do fine, will not to be hospitalized, 14% may require hospitalization, and 5% may end up in the ICU. But that changes, these percentage changes according to other factors. And if you look at age on the right side, if you're older than 80, almost 15% chances of dying. If you are between 70 and 80, 8%. Overall mortality is 2.3%. It might be a little bit lower depending on how much testing you're doing. But if you end up in the ICU, average is 50% mortality. But reports vary. I've seen reports of 70% mortality, and I've seen as low as 20 or 30% mortality. Now, I try not to scare the patients and give them all this data on the right. I usually give them the data on the left, which is true. And it's useless to put them on extra fear when you really can't do much about it. So the elephant in the room is the asymptomatic patient with COVID-19. Why? Because people who are asymptomatic tend to not use masks more than if you're symptomatic. They have longer viral shedding, which means they have greater infectious potential. The reason they're asymptomatic is because they have less cytokine generation, and therefore they don't have symptoms. I always tell my medical students that when you have influenza, the reason you feel like you've been hit by lightning is because of interferon. It's not the virus. The virus triggers interferon production from your macrophages, and that's what makes you feel so lousy. Here's the same thing. Symptoms are generated by the cytokine production in response to the virus. People who are asymptomatic tend to not have as good of an immune response as people who are symptomatic. So 12% of symptomatic individuals do not mount an antibody response compared to 40% of asymptomatic individuals. Meaning I don't know if this was confusing, but if you are symptomatic, you have more chances of building antibodies than if you don't have symptoms. And protective immunity may be not as long if you're asymptomatic compared to symptomatic patients, but we really don't know this right now. So another thing that we've learned in the last 6 months is the ethnic and racial disparities that COVID has. And if you can see on the graph in the right, Hispanics, Native Americans, and non-Hispanic Blacks have the highest rates of hospitalization. So, of course, this is not only due to an ethnic difference, it's because this is also tied to social, economic disparities. And, people who are poor tend to live more people in one room, have less access to healthcare, and they can, have higher chances of acquiring COVID. And also they have more comorbidities, more obesity, more diabetes, and that tends to give them a worse outcome. The other thing that we are learning as we speak is the post-COVID syndrome. So usually when you get influenza, after 7 or 10 days, you're basically back to normal for the majority of patients. With COVID, I would say that 60%, and depending if you had severe COVID or not, it may be a month or two before you actually go back to normal. And we are seeing some weird neurological manifestations of COVID, like Guillain-Barré's and neuritis, etc. So time will tell where this really ends up, but it's not over with the acute infection for many patients. Okay, so I don't know much about vaccines. It's not my field. I just know I need to get my flu shot every year, and I do. But with COVID, now we have a vaccine coming up really, really soon. And even if the vaccine is effective and safe, we're still going to have problems, because if you look at this statistics, 49% of Americans in general will be open to receive a vaccine. Their orange is they're not sure, and the yellow is that no, they would not get one. When you stratify this by age, older individuals, 60 or older, are more prone to get vaccinated. I don't know what the reason is, but I think that they're more cognizant that they can get sicker and have more complications. Younger people think they're never going to die, and they may be not so worried about getting a vaccine or not. And then there's ethnic differences. Whites, blacks, and Hispanics have more distrust. I'm sorry, blacks and Hispanics have more distrust on the vaccine than whites do. And it's interesting. I'm not sure what the reasons are, but I'm sure it's probably distrust in the institutions. I don't have any data for Native Americans. I know there's a lot of groups studying this right now and looking at it, but I really don't know what to tell you on trust or mistrust on the vaccine. Maybe if someone knows, they can speak up. So regarding treatment, so you are privileged, because I updated this slide yesterday because we got news. We got something new kid in the block, which is monoclonal antibodies. So a week ago when I gave this presentation, I only had remdesivir and dexamethasone. So this is the graph that shows you, this is time course right here. And the first week is the viral response. Virus is replicating and causing your symptoms because your immune system reacts to the virus. But if you're not going to do well, your immune system goes out of whack and has a very exaggerated inflammatory response. And that's when you get sick, pneumonia, ARDS, and death. So until last week, we only had 2 treatments approved by FDA with some efficacy results. Remdesivir, which is an antiviral, indicated for individuals who are hospitalized, who need oxygen, but let me put it this way, not too much oxygen. When they need too much oxygen, probably it doesn't work. And dexamethasone is, again, for individuals who are hospitalized and need oxygen, and here's the opposite. They need a lot of oxygen. That's where dexamethasone really works well. Dexamethasone decreases mortality by 30% overall, and remdesivir decreases days of hospitalization. It doesn't decrease mortality that we know of yet. Now, last Friday, I believe, there was an EUA for the monoclonal antibody that Eli Lilly, that's a pharmaceutical company, produces. This is not the same one that Trump got. Trump got one from Regeneron. Regeneron, I think is the name of the drug. It's from a different company, but the concepts are very similar. It's a monoclonal antibody that targets the surface, the spike protein of the virus. The mechanism of action is thought to be that by blocking that spike protein, the virus cannot penetrate the human cells. So the earlier you use it, the better. And actually, in the clinical trial that got that drug approved was only a phase 2 trial. That's a little bit scary. We usually go for phase 3 trials to approve drugs, but here it jumped from phase 2 to EUA. And what they showed on the trial is that patients who got the monoclonal had less risk of being hospitalized. And especially if they were obese and age greater than 65. Just to give you an idea, if you are not obese and younger than 65, and obesity measured by BMI of 35, your chances of being hospitalized was 4% on the trial. If you had those two one of those two risk factors, it was 14% risk of being hospitalized. So we have this monoclonal approved for outpatients only, without oxygen requirements, and with high risk of progression, meaning obesity, diabetes, chronic kidney disease, et cetera, et cetera. So there's the EUA has tiers of when you can use the drug and when you shouldn't. So my final comments are the following. Don't kid yourself. This is not the flu. There's still people that think, oh, this is just the flu. If you just do simple math, the flu kills 40,000 people in 1 year in the United States. This virus has killed 150,000 people almost in 6 months. So if you just do the simple math, 300,000 a year versus 40,000 a year, this is worse than the flu. For several reasons that I won't go into, but it's definitely not the flu. For those who still think hydroxychloroquine works, please do not use it. It doesn't work. There's been tons of trials showing that it's worthless. So what works to mitigate the pandemic? Mask work, physical distancing works, hand washing works, contact tracing works, public health works. We know that all these things work. We just have to implement them. And what helps moving forward? What helps us as providers, as health professionals? Following science, being perseverant, empathy, not only to our patients, but to our coworkers in these times that are very distressing. Kindness to our patients, kindness to our coworkers, to our family, to our neighbors, and finding meaning in what we do. You know, I think this is the first time in my life, I always said my hardest time working in my life was when I was a resident. I would have to be on call every other day for 3 years in a row, sleepless nights, etc. I think this has been worse. It's been 6 months, and I think I had 1 weekend off in the last 6 months. But what keeps me moving is finding the meaning that what we need to do is to help our community. And at the end of the day, if we help our community, we're helping ourselves. So I'll stop there. And if there's any questions, I'll be happy to answer them.
Thanks for a great presentation, Dr. Mara. Do we have any questions so far?
I did. I was wondering about people who wear just face shields. I mean, that's silly, right? That's not enough.
That's a great question. The face shield by itself, it's not enough. But the face shield on top of a mask, it gives extra protection. So, and there's data that even, you know, we're used to using all this gear in the hospital, but there has been, I think I presented it with this group a month or two ago. There was a WHO study that it was a meta-analysis. They looked at eye protection and face masks, not only in healthcare settings, but in the community. There were two studies that they found that they evaluated the use of eye protection, either goggles or those special glasses that have that little side thing. And they found that it was protective even in the community. Of course, we're not expecting everybody to go with a face shield out the door, especially in these political times. It might be scary, but eye protection seems to work, but not by itself. You need to use a mask and throw the shield on top of that mask, or some goggles or whatever.
What about just basically wearing like glasses? Is that
so? I have not seen a study comparing glasses by itself, but going to in COVID, but going to other situations in the past that they've been, glasses are not the same. So the glasses that have that little sidebar that protects you from that angle, they seem to work. But your regular glasses, they're not as good as the other ones. Now, I mean, common sense does not mean, logic does not mean you have the truth, right? Because 500 years ago, the logic was that the earth was flat, but it wasn't true. So I would say that wearing glasses is probably better than not wearing anything, because if someone is talking and throwing particles at you, at least if they're in front of you, your glasses will protect you. But in the healthcare setting, they don't work as well as the other eye protection. The goggles or the face shield or the glasses with special side covering.
I have one question. Would you expect a patient on a cytokine inhibitor like Stelara to be more likely to be an asymptomatic spreader?
That's a great question. You know, logically speaking, I would, because they have a less immune response and they would have less symptoms. What we know about people who use biologics because of different diseases is that they don't seem to fare worse compared to people who don't, which is interesting. But I haven't read anything that regarding their symptoms. But I think that's a very logical thought. We in other disease states, like people who have their immune system blunted, like patients who are transplanted and are on chronic immune suppressant therapy, or patients who are on chronic dialysis. As a physician, when they come to the ER for some bacterial infection, they don't seem to be as symptomatic as the others, but at the end, they get as sick as the others. They just seem better. So, Chrissy, I haven't read an article looking at that in particular, but I think that's very reasonable to think.
Any other questions or comments before we move on?
I had one question. Kind of similar to what Emily had asked, but those people that wear just like those, they're like almost like a ski type of deal mask. I feel like those don't really do anything.
Like a scarf type?
Yeah.
Yeah, those are not as good as your cloth masks. I mean, they've been evaluated because first, they only have one layer. Second, they're not fitted in your face. They have a lot of openings on the side. So those are not as good as wearing a cloth mask. So for the public, I would say the minimum requirement would be to wear a 2-layer cloth mask. That at least a 2-layer. More layers, the better. But there's a barrier to breathing. There'll be if you increase the layers too much, you won't be able to breathe, period. So that's not good. But that's the recommendation. Now, and I'm saying this is my opinion, but if they have an option of having a surgical mask, I would say use a surgical mask if you have one, if you can access one.
Okay, great. Now we'll move on to Christy Duke for her presentation on Vaccine 101.
Thank you, Brian. I appreciate it. Yay, it worked. Brian has had a bad history of his computer freezing up when he shared a screen, but we got it. Thank you, everybody. I want to first of all thank Dr. Harry Brown, who helped pull together these slides. He did the bulk of the work, and so I really appreciate his help in this. I just wanted to go over a few objectives. Go ahead and go to the next slide, please, Brian. So during this presentation, I hope that you take away and become familiar with terms about immunity and vaccines. I'm going to offer some familiarity with vaccine safety measures and teach you about some of the true cautions about vaccine and also some of the myths associated with vaccines. I know that there are a lot out there. So I'm going to briefly just go over all of these things. But first, I'm going to start with, go ahead and go with some definitions. You can go to the next screen, Brian. So immunity, hold on, I've got to move my thing. It's blocking my screen, so I can't read it. Immunity is the ability of the body to tolerate self and eliminate foreign material or non-self. So really when we think about, foreign entities coming into the body, so the body has to be able to recognize itself. Dr. Mira just recently touched basically on autoimmune diseases with the drugs that we were just talking about. And that's a case where your body is recognizing itself as non-self and is actually attacking itself. So that's really kind of the very basic definition of immunity. The immune system is broken down into two main parts, the innate immune system, and that's just what our body, the tissues our body is made up of to protect ourselves, to prevent diseases. So your skin is part of the innate immune system. Your mucous membranes are part of that. The moistness in your nose, as we know, you get flu more often in the wintertime. One of the reasons for that is because the mucous membrane in your nose often dries out with the cold weather, and that leaves you more open to the flu. White blood cells as well are part of the innate immune immune system. The adaptive immune system is the part of the immune system that develops defenses against specific organisms, toxins, or other antigens. And so that's your cellular response to diseases, which Dr. Mira touched on briefly. Go ahead and go to the next slide. So what is an antigen? I know we hear that word a lot. An antigen simply is non-self. It's a substance foreign to the body. It can be a live organism, such as a virus, bacterium, or parasite. It can be a toxin, and it usually triggers an immune response. You know, we talk about people that have transplants. And they get a donor kidney or whatever. Well, you have to take drugs so your body doesn't recognize that kidney as a foreign invader, because your body is finely tuned to reject things that are not part of itself. The immune response, you'll hear that. That's simply the production of antibodies in response to an antigen, which again is a foreign substance in the body. And the antibodies, we will hear that word a lot in the coming months with the vaccination. Those are protein molecules, and they work to help eliminate the antigens. And that's just kind of broad definition. So I wanted to talk briefly about the immune system. I'm not going to go into just too much detail. I want you to think about how you get sick. We know that the antigen enters the body. Okay, so we know that that's happens. Once it enters the body and enters the cells, it has to replicate, which means it copies itself, and then it infects other cells. And after it infects so many cells, you become ill. After the virus enters the body and replicates, it's taken up by an antigen-presenting cell. This cell presents the virus for recognition as a foreign body. So when I was prepping for this, I thought of it like that's some sort of evil debutante who's being presented to society, which is your immune system. So it presents the antigen to be recognized as non-self. Then there's some cells called the T helper cells, and these function as kind of a sort of cellular immune system cheerleader that rallies a lot of the other cells that are needed to help fight off the infection. Go ahead and go to the next slide. After this, B cells, they make antibodies that can bind to the viral antigens. And that allows the cytotoxic, cyto means cell and toxic is self-explanatory. They come along and they bludgeon the infected cells that are sick. And that's what fights off the infection. Now, as Dr. Mira talked about earlier, this is the part that makes you feel lousy, this cellular response. It makes you feel bad. Takes a lot of energy to be sick and to mount this cellular response. And typically our bodies like to try to conserve energy. So once the infection is defeated and has gotten under control, there is no need to maintain that level of cellular response. So your body, there's cells that come along called memory cells, and their job, they're the grudge holders of the immune system. They're the ones that come along and they remember the antigen that came in, and so they're kind of like the bouncer. They do not allow it to come back in. And I do want to say, I want to have the caveat, everything that I'm talking about here is really in relation to viruses. There are some caveats specific to bacteria that I'm not going to go into. So anyways, the memory cells, they serve as the bouncer to help prevent the same infection from reoccurring. Okay. So that leads us to vaccines. So how do vaccines work? Well, what they do, by and large, is they mimic the natural infection process without the middle part, without the getting sick part. That's our goal in creating vaccines. So they create the substance that mimics the natural antigens, and there's a variety of different ways in which they do this. and they produce the vaccine. The vaccine is injected. And the immune system responds to make antibodies and sometimes a T cell response. And your body fights that off. And then those memory cells come in and remember and serve as the bouncer, so they prevent a real infection from coming in and making your body sick. So that's really, they just take out the middle part, by and large, of the getting sick part of the infection. So go ahead and go to the next slide. So some of the advantages of vaccines. A vaccine, as I mentioned, allows a person to develop immunity without having to suffer the actual disease, right? So that's a good thing. Sometimes the immunity produced by the vaccine is not as good as it would be with natural disease. And that's oftentimes why we have to have boosters, because sometimes it wanes too. But in many cases, it can be good or even better. Vaccines, we have a long history of vaccines. It has eradicated smallpox and greatly decreased death, suffering, and disability from many other diseases. Go ahead and go to the next slide. So if we were to design a perfect vaccine, and as we know, no vaccine is perfect, it would be safe, no serious adverse effects or minor adverse effects, either acceptable and expected. And I'll talk a little bit about expected in a minute. Effective, it produces the antibodies and the T cell response, so it works really well. It's inexpensive. We can manufacture it in large quantities. It's easy to administer to large populations. And it has proven efficacy in many different populations. And efficacy is how effective a vaccine is in clinical trials. So it needs to have at least 50% efficacy for FDA approval. The current vaccine, the current COVID vaccine, which is, why am I drawing a blank on the manufacturer? Pfizer. The Pfizer one is showing efficacy of about 90% at this point in time. So I'm going to talk a little bit about the vaccine technologies that are currently available. And there's a lot of them. And again, these are, I'm going to go over these, but some of them I could spend a whole session on each of these. So this is going to be very high level. So if you think about vaccines, like from the beginning of when we had vaccine, very first that's not on this list is just live virus, just a virus that you put into a body. And the very first vaccine was smallpox. And what that was actually was a cowpox. There was a scientist who noticed that milkmaids who were around cattle did not get smallpox. And he hypothesized and tested, I wonder if cowpox protects from smallpox. Sure enough, it is a related disease, and it did. So the very first vaccine in the late 1700s was just simply cowpox that they injected in people and hoped for the best. But it was able to reduce smallpox, and eventually we eradicated smallpox from the planet. Next in the production cycle are inactivated viruses. Flu in the 1940s was one of the first ones. And then live attenuated. And what this is, it means that it's a live vaccine. So it's taken from the virus itself, but the virus is passed through many different stages to change it, to make it weaker. You can think about it like breeding plants for a desired characteristic, a certain flower color. It takes many different cycles to be able to do that. Measles is one of those, and also the nasal flu is live attenuated. The polio one is an inactivated, and then first was inactivated and then oral live attenuated. Those of you who are around my age, I'm 48 now, I remember getting a polio vaccine on a sugar cube. But because polio became such a rare disease, the oral virus had a slight chance of actually causing polio, reverting back to its natural state. So getting the vaccine became higher risk for contracting polio than not getting vaccinated, because we had done such a good job of knocking polio out, that we switched to the injectable polio so that that risk was greatly reduced. So before we switched, we saw about 5 to 10 polio cases per year due to the vaccine. So somewhere between the time I was 12 to my next polio booster, we switched, because I remember getting the sugar cube one. Go ahead and go to the next slide. No, back up. The other ones highlighted in green: viral-like particle, replicating viral vector, non-replicating viral vector, DNA, and RNA, are newer technologies. Now, these technologies, I'm not going to go into any great detail on these. There's some advantages and disadvantages. One of the disadvantages, depending on the way you look, it requires genetic technology, and that sometimes can be a little bit of a trigger to people, and that's kind of a scary word. It depends on the way you look at it. As I said, Dr. Brown helped me pull together these slides, and it was his opinion that kind of the messenger RNA seems to be theoretically one of the safest around, because it cannot insert you into your DNA. Dr. Mira, are you kind of in agreement with that statement? Okay.
Yes, sorry, couldn't find
That's okay, no problem. So the RNA virus, the first 2 COVID vaccines are going to be RNA vaccines. They've been in development for about 10 years. It's not hard to make, but it was hard for them to figure out how to get it into your cell to replicate. And that's really been the challenge. And that's just recently what they figured out. But the development of the vaccine, of RNA vaccines in general, it's been happening for quite some time now. Go ahead and go to the next slide. So, and as I said, it's been under development for about 10 years that they've been doing that. So how did they develop vaccines? What are the steps to doing that? So potential vaccines are first tested in animals: rats, mice, non-human primates are the usual test subjects. I know I went to Tulane School of Public Health, and we had a primate lab. I never went to it. I don't want to go there. I don't want to see how the sausage is made, but they did have a primate lab in which they tested some of these things there. I can imagine with the RNA vaccines that there was quite a lot of testing. As I said, they had trouble figuring out how to actually get it into the cell to replicate. They would have done that work on animals to try to figure that process out. After that happens, then human trials are conducted after safety and effectiveness are proven on animals. And there's 3 phases for that. Phase 1, a small number of volunteers, and they're mainly just looking for safety. We're going to inject this, see how it goes, we'll see if it's safe, see if you have any major side effects. Phase 2, usually several hundred volunteers looking for an optimal dose. And phase 3, thousands of volunteers to test for how effective it is. Before a vaccine is approved, the safety must be demonstrated. So that occurs throughout the entire process. Go ahead and go to the next slide. And I will tell a story. You hear about adverse reactions and adverse events, and those are 2 separate things. This does seem to be splitting hairs a little bit, but it's really not. Adverse reaction, it's actually caused by the vaccine. It is a side effect. Most commonly, they're mild: sore arms, body aches, headaches, but some can be serious. An adverse event is any event following a vaccination. It may be a true adverse reaction, but it may not be. And it may only be coincidental. And the story that I was going to tell, when I was in public health school, I actually volunteered for a clinical trial for painkiller for cancer patients. So I was in, I believe I was in phase 2 or 3. I can't remember which. I am pretty sure I got the placebo. It was oral. It was a sublingual tablet. And if you remember the taste of paregoric, it's nasty tasting, and that's the opiate base. So I got mine, and mine just tasted minty fresh, and everybody else in the trial was complaining at how bad it tasted. Then everybody else was complaining about how sleepy they were, and I felt fine. So I'm pretty sure that I got the placebo. So I got a headache. I frequently get headaches, so that's not uncommon for me. I got a headache and they had to record it. And so that would be an adverse event because more than likely I got the placebo, but I also got a headache, and they've got to record that as an adverse event. So a lot of times when you see that big long listing or hear that big long listing on drug commercials, those are adverse events. They've got to record each and every one of those. So just a little anecdote. Go ahead and go to the next slide. Thank you. So what's a contraindication? So there's a couple of things for when you should absolutely not give a vaccine. If you've had a severe allergic reaction to a vaccine or a vaccine component in the past, or if you've ever had encephalopathy within 7 days of a pertussis vaccine. That is a true contraindication when you should absolutely not get a vaccination. Now, with that said, there are relative contraindications, which requires an individualized evaluation to determine whether it's safe. Pregnancy, some vaccines are safe in pregnancy, some are not. Immunosuppression, Dr. Mira and I were talking about immunosuppressive drugs. It's probably best for most of those patients to get a vaccine. It helps to protect them, but again, they need an individual evaluation to determine that. Any severe illness, recent blood product administration, sometimes those will interfere with vaccine immune response. Always ask screening questions. I know if we go to Walgreens to get a flu vaccine, they've got a form that you've got to fill out and check all of those things and to make sure that you don't have any contraindications, or they evaluate further whether the contraindications that you have listed, it's okay to move forward. Go ahead. So there are a lot of myths out there for contraindications. A mild illness, you can go ahead and get vaccinated. You don't have to wait till you are, 100% in tip-top condition to get your vaccine. If you've got a cold, you can generally go ahead and receive a vaccination. Antibiotic therapy, same thing as the mild illness one, you can go ahead. If there's a pregnant or immunosuppressed person in the household, you can generally go ahead and receive a vaccination for a viral illness. I believe that there may be a few bacterial illnesses where you would have to not get vaccinated, but again, we're talking about viral ones. Breastfeeding, go ahead and get vaccinated. Preterm birth, we need to protect those preemies. We like to get those babies protected as much as we can. Allergy to products not in the vaccine. Family history of vaccine adverse events. So just because your mother had an allergic reaction doesn't necessarily mean that you will. Tuberculin skin testing, although with some live virus vaccines, it can interfere with the accuracy of the TB test, although it will not cause any complications with the vaccine or getting sick. It just may not, the TB skin test may not be able to be read accurately. Okay. Now that's not to say we shouldn't be cautious. Rare serious adverse reactions do occur. Allergic reaction can happen, about 1 in between every 200,000 and 600,000, just depending on the vaccine. It can happen. Injection site infections can happen, so that's a reason to be cautious. When I started public health school, the buzz was the rotavirus vaccine was causing, it's a severe gut complications in babies. about 1 in 11,000. However, the current rotavirus vaccine does not cause this, but I mean, that's still a reason we need to be cautious, and that's still a reason that we look and we monitor for those severe side effects. The whole cell pertussis vaccine, it's not used anymore, but it did cause high fevers in about 1 in 330 people. The oral polio vaccine, remember that was a sugar cube one that I mentioned, actually caused polio in about 1 in 1 million cases. And some people got Guillain-Barré syndrome with the swine flu vaccine, but not since then. So there are reasons to be cautious, and there are reasons to monitor vaccines. And that's one of the things that the large clinical trials do, is that they are able to monitor these things. So that's not to say that we shouldn't be cautious, because we should. Go ahead and go to the next slide. Vaccine myths, autism. This is one, Dr. Mira, I am sure you probably still hear this in your practice. Vaccines do not cause autism. In 1998, Andrew Wakefield published a paper in The Lancet, and I didn't realize the study was that small, just 12 kids, that suggested that the MMR, measles, mumps, and rubella vaccine caused autism. Multiple studies after that, because remember, we have to science, one of the basic tenets of science is we need to be able to repeat the results, failed to show a connection. In 2010, the article was retracted due to findings of fraud. So he faked the data, and he was funded by lawyers in lawsuits against vaccine producing companies. So, you know, articles, journal articles are rarely retracted. As science progressed, sometimes they are contradicted, but they're rarely retracted. So the fact that the Lancet retracted this was a really big deal. Go ahead and go to the next one. Other vaccine myths, mad cow disease, HIV, AIDS, asthma, diabetes, SIDS, cancer, diabetes. No causal link has been found to any of the above, but falsehoods still present. I'm not going to read that, but that's a funny comment. The original Salk polio vaccine was not used after the oral vaccine. Yeah, I believe that that is correct. Hold on, I lost the chat window. You know, I don't know. I think you're correct, Mary, that the Salk vaccine, that was the first one, and then they kind of perfected oral polio, but I don't know for sure. Dr. Mary, do you know the answer to that?
Give me 1 second. The original Salk polio vaccine was not used.
Do you know anything about
Okay, so I think that's correct. Now, you know, the Salk, the good thing about the okay, wait. So was the Salk vaccine the injectable form?
I don't think so.
Because originally, I remember there were two. One was the oral, which is live attenuated virus, and I believe the Salk vaccine was it was dead virus. It wasn't live attenuated.
It was Salk was 3 injections, so
Yeah.
it was dead.
Yeah. So I know that it had some role in patients who were immune compromised, because you couldn't use the live attenuated vaccine, because it can cause polio.
Yeah.
But I don't know if it was completely not used anymore. I don't remember that.
Yeah. So the conclusions that I wanted to make, vaccines can rarely cause serious side effects, and that's where proper screening comes into play. However, they have prevented billions of cases of illness. If we think of the illnesses that people used to die from that we're just not dying from anymore, that's thanks to vaccines. There is so much misinformation about vaccines and social media. So always use trustworthy sources of information, CDC website or medical sources such as UpToDate. As I mentioned, go ahead and go to the next slide. Dr. Brown helped me pull this together, and here are some of the resources and citations that he used to pull this together. And that's all I have. Are there any questions for me? And if I can't answer, maybe Dr. Mira can chime in. I'm not an immunologist, so.
So, Chrissy, I have I know the question doesn't have an answer, but I'll just
Okay.
pose it because it was asked to me by a patient the other day. So I don't know if I presented with this group or not. A few weeks ago, I did a presentation on Guillain-Barré as a complication of COVID-19. And there was this report of 73 cases worldwide. It was a meta-analysis. I mean, they did a case series. So there seems to be an association between COVID and Guillain-Barré, like, you know, many other viruses or Campylobacter. Sorry, I didn't quite catch that. My series is betraying me. So I had a patient call me, said, my husband got Guillain-Barré due to the influenza vaccine, which has been reported and associated with. What do I do with the COVID vaccine? And I said, well, really, I don't know. I mean, I don't think we have any data, but those questions are going to come up. And I don't know what, you know, I would be very, so it's difficult. I would be very stressed to recommend a COVID vaccine on someone who had a Guillain-Barré due to an influenza vaccine, especially now knowing there is an association between COVID and Guillain-Barré. But on the other hand, you know, Guillain-Barré, COVID is such a severe disease in some patients that if the patient has many risk factors, so it's going to be difficult. I'm just throwing that out there because these questions, and I had two patients call me for the same reason. I don't know.
Well, I think one of the benefits, if you can call it that, of us having so many cases right now is that we're getting a lot of data on these trials. So that's, I mean, that's good because we have so many cases, we're able to test out more. So
Right.
And you know, hopefully the data, all we can do is report on the data, but if the data is non-existent, I think, you know, that's a really good point that we're going to have to continue to look at.
Thank you.
I have another polio question.
Don't get it. That's my public health recommendation.
Is it so when I was I worked with in a Palestinian refugee camp maybe 5 years ago, and I was given the polio vaccine again. Is it okay to get it? Like, is that typical to renew it? I mean, I had it as a child.
Brian will know. Brian, do you know the polio schedule? Dr. Mira will know. I don't know it off the top of my head. Did you have oral or injectable?
Oral.
Okay.
If you travel outside, let's say, to work, they usually give it to you. They suggest it, yeah.
I mean, it's cheaper. Oral polio is a lot cheaper to produce than injectable. And so that's why countries with lower resources will continue to use it. I know that the expense of injectable is high. I think we just made the decision in the United States to assume that extra expense because there was higher risk of contracting polio from oral than it was to contract it from not being vaccinated.
The other beauty of the oral vaccine is that you vaccinate one individual and that the individual vaccinates unintentionally a lot of people because they shed the virus on their stool. And so, you know, you're spreading the vaccine by the same way the disease is transmitted. So that was the other pro, you know, that why the oral vaccine got a lot of popularity. Because people can be contagious of the vaccine. Let me put it that way.
Yeah. So you weren't one of the 1 in 1 million, Emily. You're good. No polio.
Yeah.
Good.
Yeah, I think I'm good.
So I don't have, if anybody has any other questions, I will say I shared on the call yesterday, my mother remembers the 2 summers that she was not allowed to play outside because of polio. And when the Salk vaccine was announced, she said all the mothers ran outside and were talking in the street and were so excited because finally a solution had been found. And so, I think we're really cynical, or a lot of people are really cynical about this vaccine, but I'm hopeful. So I'll just leave us with that.
Okay. There is the survey link in the chat box that Emily posted. If you will click on that and fill out the survey, that'll help us develop our next sessions. I don't have anything else. Our next session is going to be December 4th. So it's not in 2 weeks, it's actually in 4 weeks. So
Yeah, we shifted it because of the holidays.
So one thing, Brian, before you close, is that now the Eli Lilly monoclonal is being distributed by IHS. So we're getting 500 doses next week, and I'm sure that many IHS site will get some doses depending on the population that's served. So there are some nuances. We're actually preparing to start this next week because we're getting the doses, I believe, Monday or Tuesday. So if anybody needs any advice or help on how to roll this out, pragmatically in your system, please feel free to reach out. If you have a lot of those questions, maybe we can do a little meeting in between, and I can just share with you what we're doing, because I've been working on this for the last 24 hours nonstop, and the concept is simple, but implementing it's a little bit more complex. This isn't a one-time infusion, but you have to have certain accreditations for your infusion and a bunch of things like anything we do. So let me know if you need anything on that. Okay.
Yeah, you can contact us as well. Brian was working on, we just released a prioritization document about who to prioritize. And I know Brian's working on some eye care or Q-Man or both. Eye care logic to help you impanel those patients. So just let us know.
well, everyone can have a great rest of your day. Thank you so much and have a great weekend.
Thank you.
Bye.
Thank you.
Bye-bye.
Bye.